Hello guys, welcome back. So in the previous lecture, we had studied the basics of the pathophysiology of diabetes, and in this one, we'll be trying to cover the diagnostic criteria and diagnostic test for diagnosing a patient with diabetes. Okay, so like always, we'll not go with the PPT format. I will explain you from my own experience and notes which I have made for you all. So yes, basically generally we measure the patient of diabetes or in normal also for routine screening. There are different tests which are used, right? So we'll quickly write them down. First one is FBS, which is fasting blood sugar. The second one is PPBS, okay, which is the post prandial blood sugar, the 2-hour plasma glucose, right? The third one is what we say HbA1c, or generally what we call as the confirmatory test for diabetes. The fourth one being the gold standard test, okay, like to confirm diabetes for sure, it is OGTT, which is oral glucose tolerance test, OGTT, okay. This is very important test. Then the fifth one is urine and glucose, which is glycosuria, right? And the sixth one being random blood sugar, and the seventh one what we call is C peptide test, okay. This what you are seeing here is a general panel of blood sugars which we expect to study in a patient of diabetes, or when you want to confirm or diagnose a new case, a fresh case of diabetes mellitus, right? In the second part, of course, we'll go and study these tests in detail, but in the second part what I wanted to give to you from this video aspect is that there are certain rare cases and conditions and also diagnostic tests available to confirm your diagnosis, right? So if at all a patient with severe pathologies come to you and they have done those tests of diabetes advised by their MD doctors, then you must be able to analyze and evaluate those tests as well. We'll come that in the second section of this lecture. But first, let me begin with the fasting blood sugar, right, my friends? So what is the fasting blood sugar? It is generally a very basic investigation done to rule out a patient that could be diabetic or who is healthy, right? So what is it? It measures the blood glucose levels after at least 8 hours of fasting, usually overnight. So 8 hours is must for fasting. And what is the exact physiology which we understand while doing this test? It is during fasting insulin levels should be low and glucose is maintained by liver gluconeogenesis and glycogenolysis. In diabetes, this regulation fails, leading to higher fasting levels. So reference range as given by the local Indian laboratories and the IMA, and also like what we call it from the American standards, is that a normal person's fasting blood glucose FBS should be in the range of 70 to 99 milligram per deciliter, okay. Now if a patient is pre-diabetic, his range would lie from 100 to, not 120, but 100 to 125 mg milligram per deciliter, and in the patients who are confirmed diabetic, it will be more or equal to 126 milligram deciliters. But remember here that this should be on 3 plus or more occasions, okay. This one above 126, you must if a patient comes to you and he has little high fasting blood sugar, you must check his fasting blood sugar at least on 3 plus occasions to confirm that whether it is constant or no, okay. Some clinical insights which I want to give here for FBS would be that elevated fasting blood sugar is the earliest indicator of impaired glucose metabolism. It can also falsely be low if the sample isn't tested quickly due to glycolysis, and may be falsely normal in early type 2 diabetes mellitus, in which postprandial rises earlier than fasting, okay. So we'll study all the different clinical scenarios in this video itself, but in the later half. The second test, the postprandial blood sugar. So what is it? It measures the glucose levels 2 hours after a meal or glucose load, which is 75 gram glucose if OGTT is applied. So what is the physiology? After eating, insulin is secreted to lower the glucose surge. in diabetes, insulin either does not come like in type 1 or is ineffective like in type 2, so sugar stays high. Now the reference ranges for postprandial blood sugar, let us note it down, that the normal is always less than 140 milligram per deciliter. In pre-diabetic case, it could range between 140 by 199 mg per dl, and in confirmed case of diabetes mellitus, it is always equal to or more than 200. Okay, so 200 is the reference range that you need to remember whenever a patient comes to you with a random blood sugar or a ppbs or a fasting sugar of more than 200. Your ears should get alert, and you must be into your investigative zone, that what is wrong in the body, what is this person going through, right? Mental stress, lot of things, which is of course the homeopathic part, right? But in clinical investigative part, remember that 200 is the threshold of our human body. The blood sugar level should not be more than 200, and of course it should not be also 200. So your role and duty as physicians should also be to help patients of pre-diabetic conditions, that they do not fall into the vicious, you know what we can say, the silent killer diabetes mellitus. And there is a very good and a very high scope of them to convert back to normal levels and not turn diabetics if they take care of their lifestyles and many more things which you as doctors must advise them. Okay, so some clinical insights that we must remember for ppbs is that often the first to rise in early type 2 diabetes mellitus. Okay, so many times in some fresh cases of diabetes mellitus, you might find that the person is having normal or slightly deranged or slightly high fasting blood sugar, but his ppbs is extremely high. So your ears should get alert, and you must put on your investigative spectacle. It is used to monitor post meal spikes that FEBS may miss, and particularly it is important in gestational diabetes, which we will cover ahead, right? Now my friends, one of the most important tests for diabetes mellitus is the HbA1c. Now what is it? So HbA1c measures the average blood glucose over 2 to 3 months by checking the percentage of hemoglobin bound to glucose. Okay, now I feel that we must study this test in detail, so we'll go into the depths of HbA1c. So HbA1c, my friends, okay, which is also known as hemoglobin A1c or glycated hemoglobin or A1c. Alright, so HbA1c is a form of hemoglobin Hb that gets irreversibly coated with sugar in the blood, like sugar caramelizes on the toast or on your popcorns. It reflects how much glucose had been sticking to the red blood cells over the past 2 to 3 months. Basically, it's a estimate of 3 months, which is the average lifespan of RBCs, which is about 120 days. Right, my friends? So what does it measure? It measures the percentage of glycated hemoglobin HbA1c out of total hemoglobin. So for example, if 100 hemoglobin molecules and 7 sugar stuck, so HbA1c is approximately 7%. Okay, why it's used? So the clinical relevance: diagnosing type 2 diabetes mellitus, monitoring long-term glucose control in known diabetics, detecting compliance to treatment, and predicting the risk of complications like retinopathy and nephropathy. Now the reference range as per Oxford and the ADA goes as that the normal HbA1c is always less than 5.7 percentage. The pre-diabetic condition arises from 5.7 to 6.4%, right? The diabetic mellitus condition arises when the HbA1c is more or equal to 6.5. It confirms with a second test unless the patient is symptomatic. Now for diabetics, you must remember that for diabetics, a less than 7 HbA1c means that the excellent control is there over his sugar profile, and if it is more than 8, you must remember that the blood sugars are poorly managed, right? This is condition for the diabetic people. So hemoglobin lives inside our red blood cells and carries oxygen. The glucose floats in your blood. When too much of glucose is around, it starts sticking to hemoglobin. The more sugar, the more sticky the hemoglobin becomes, and it results in high HbA1c. So basically, it's like hemoglobin being dipped in honey every day. The longer the exposure, the stickier it gets. Right now, what we compare with different HbA1cs is not that of it's not that important. But now, what I want to tell you here is very important, that HbA1c can be misleading at times, right? So you please make notes of these misleading HbA1c readings and when will it occur. So, let us begin. HbA1c assumes normal RBC lifespan, right? So, it is falsely positive or false low HbA1c in cases of hemolytic anemia, chronic blood loss, renal failure with dialysis, recent transfusion, and pregnancy. In these conditions, you must not rely on HbA1c itself and then test your diagnostic criteria with other investigations. And to be very different on the other part, it can be falsely highly positive in cases of iron deficiency anemia, splenectomy, alcoholism, and uremia. So that's when a new test will be of highly useful to you when you get false reading from HbA1c test. So which is the two tests that you must remember when you have HbA1c giving you false readings like in the above case? So the first one is fructose amine. Okay, fructose amine is a test which I'll come to ahead in this lecture, and second one is glycated albumin. Okay, these are the two confirmatory tests when HbA1c gives you false results. Okay, my friends, and lastly, also you need to remember a few pointers for HbA1c in respect to the HbA1c percentage with estimated average glucose. Okay, so HbA1c with respect to estimated average glucose. Okay, so whenever the HbA1c is 5, right, the estimated average glucose is considered 97. Whenever it is 6, it is considered 126. Whenever it is in the range of 7, the average glucose is 154. Whenever it is in the range of 8, the average glucose could be 183. Whenever it is in the range of 9, the average glucose should be around 212. And whenever it is in the range of 10, the person definitely has a high blood sugar of more than 240 mg per dl, and mg per dl which we have covered easily in our first lecture, right? So use these numbers to translate the values and keep in your back of the mind when you're treating patients of diabetes, right? So yeah, lastly, some clinical pearls for your HbA1c learning could be that HbA1c doesn't need fasting. It's less affected by day-to-day sugar fluctuation, ideal for busy patients who can't come to multiple fasting or postprandial tests. It is useful for diagnosis if asymptomatic, repeat it to confirm. Always correlate with RBC status before relying on it. So this is of utmost important, that always rely on the CBC, which we'll be covering in the coming series, then concluding on the HbA1c report. So this is a very important point. Always correlate. In gestational diabetes, HbA1c is not reliable. We instead use the OGTT test, which we'll be studying now. Use of HbA1c to predict microvascular risk is very helpful, like your risk to the retina, kidneys, and nerves. And some labs use HPLC or boronate affinity chromatography for high accuracy. Okay, friends. So this was regarding your HbA1c. Now we move on to the next test. The fourth important investigation for cases of diabetes mellitus is the oral glucose tolerance test, OGTT. Okay, OGTT. What is it? Blood glucose and blood sugars is tested before 2 hours after giving 75 gram glucose orally. So you give 75 gram glucose for the patient to drink, and then see the physiology behind it. Okay, 75 gram glucose is given to the patient. Now reference values. Oh, the physiology before. This checks how well the body handles a glucose load. It's a stress test for beta cells and insulin sensitivity. Okay, so this is basically a stress test, like the one we do for our heart as well, which we will be studying in this coming series. But yeah, to stress test and to check the efficiency of your organs, specifically the pancreas, this test is done. So the reference values of the OGTT should be fasting less than 100. Okay, 2 hour reference range should always be less than 140, and if the patient lies between 140 to 199, the impaired glucose is indicated, And lastly, when it is more than 200, of course, we all know that it's a case of diabetes mellitus. Okay, so some clinical pointers to remember here is that OGTT is gold standard for gestational diabetes confirmatory test, sensitive but cumbersome. It needs fasting, 2 hours wait, and the patient compliance. So this is again a very big issue, that patient must have enough time, because you test it 2 hours before you, and one test you do 2 hours after taking the 75-gram glucose. And it is great for detecting hidden diabetes in high risk group like PCOS and family history. Okay, this one's very important. PCOS plus family history, strong family history, you must rule out diabetes by OGTT. The fifth test, my friends, for confirming glucose and diabetes is glycosuria. So what is it? It detects the glucose in urine. Normally, our urine should not contain glucose, my friends. But the physiology goes as that kidneys reabsorb glucose up to a threshold of 180 milligram per deciliter. If blood sugar exceeds that, glucose spills into urine. The normal reference range, which we'll be studying in the urine analysis as well, is negative. Normal should be negative, and glycosuria is highly seen positively in diabetes patients, pregnancy, and sometimes in renal glycosuria. Okay, so clinical insights, my friends. So positive urine glucose suggests uncontrolled diabetes. It is not a reliable diagnostic tool, but a cheap early screening in camps if you can like do it. And you know, in some patients it can be seen that with low renal threshold, even if blood sugar is normal, you might find sugar in your urines, right? The sixth diagnostic test, my friends, is random blood sugar test. So what is it? Blood sugar checked anytime without regards to any meals. So to be very honest, your random blood sugar level should not be more than 200. That is the baseline, right? And the seventh and often unlooked test for diabetes is the C peptide test. Okay, this is a very important test which we must keep, and which we generally do not study when we study diabetes, is that the C peptide test. Now what is C peptide test? It measures the endogenous insulin secretion indirectly. C peptide is produced when insulin is made from proinsulin. So what is its physiology? In the type 1 diabetes, it is either low or absent. The C peptide is either low or absent in type 1 diabetes. Of course, because we know that in type 1 diabetes, insulin is only not produced because the beta cells of islets of Langerhans are attacked by its own immune system, and its auto antibodies, right? So in type 2 diabetes, it could be normal or high, but insulin is not effective. Okay, so C peptide, generally if it is very high, you can consider it alarming and as a diagnostic tool for diabetes mellitus. So the normal fast reference range for the C peptide in fasting goes to 0.8 to 3.1 nanogram per ml. Okay, remember this and write it down. Clinical insight, it helps us to distinguish between type 1 and type 2 diabetes. Okay, so this is the most important criteria for, you know, distinguishing between whether your diabetes is type 1 or type 2. So you simply do a C peptide test, alright, because you will know that in cases of type 2 diabetes mellitus 1, the C peptide will be low or absent at like completely. Okay, so it also evaluates your beta cell functions, because your beta cells secrete insulin, and it is useful before starting the insulin therapy, right? This is a concern of your MD or DM doctors of medicine, especially the diabetologist. You know, they will do your full profile, then they will study all the different parameters, and then when the blood sugar levels are extremely high and nothing helps, then unfortunately or fortunately you will have to be shifted to insulin units. Okay, my friends, so these are the basic tests, my friends, which you need to remember when you are studying and doing cases and the evaluating cases of diabetes mellitus of your own patient. Okay guys, so now we will be studying the advanced test or the rare diagnostic test for diabetes mellitus, my friends. So in this again the C peptide one comes up because C peptide test is not generally done, you know. So C peptide test, like I've already explained to you, is a connecting peptide released in the equal amounts to insulin when proinsulin splits into insulin plus C peptide. Unlike insulin, it's not degraded quickly by the liver, so it gives a more accurate picture of endogenous insulin secretion, and the normal range of this in fasting lies from 0.5 to 2 roughly nanograms per milliliter. ml, and in postprandial it is 1.5 to 5 nanogram per ml. Okay, the clinical use of these is like what we have studied is to distinguish between the type 1 and type 2 diabetes, to confirm latent autoimmune diabetes in adults LADA, to detect insulinoma, tumor secreting insulin, and lastly to monitor pancreatic beta cell functions in MODY or after islet transplant, which we will be studying up ahead. So what are the interpretations of this test? If it is low C peptide, then it is maybe type 1 diabetes mellitus or advanced B cell burnout, beta cell burnouts. And if the C peptide is quite high, it is indicating insulin resistance, like in type 2 diabetes mellitus and in cases of insulinoma. So sometimes one might miss this rare condition of insulinoma, and that is confirmed with high. So now I guess we are thorough with the C-peptide test. Now we move on to the next test, which is autoantibodies in type 1 diabetes. So this test is useful in new onset diabetes in children or young adults, especially when clinical features are confusing. So what are the major autoantibodies? The first one which we write here is GAD65, which is the full form of glutamic acid decarboxylase. Then we have the IA2, which is insulinoma associated protein 2. Then we have, my friends, ZNT8, which is zinc transporter 8. And lastly we have the IAA, which is insulin autoantibodies. And why it matters? Because autoantibodies confirm type 1 autoimmune etiology and may be useful in identifying LADA, latent autoimmune diabetes in adults who often present like type 2 diabetes mellitus initially. So these autoantibody tests confirm type 1 diabetes mellitus, and you must remember when you are studying. The third test, which is the fructose amine test. Okay, my friends, yeah, fructose amine. So what is it? Measures the glycated serum proteins, mainly albumin, instead of glycated hemoglobin, HbA1c. It reflects average glucose levels over the past 2 to 3 weeks. Okay, so the normal range here, my friends, for fructose amine is 205 to 285 micromole per liter. Okay, you need to remember this one. And also remember that it is glycated serum proteins. Okay, fructosamine are glycated serum proteins. Now when do we use this test? It is used in patients with anemia, hemoglobinopathies, or CKD where HbA1c is unreliable, like I have said in the previous slides. Okay, and to monitor rapid changes in glucose, example pregnancy or after therapy initiation. Then the next test we have, my friends, is the 1,5-N hydro glucitol, which is in short 1,5-AG. Okay, so what is it? A glucose like sugar normally reabsorbed in the kidneys. High blood glucose causes glycosuria, which competes with 1,5-AG and reduces its reabsorption, and its level eventually drop. So clinical utility, it is sensitive to postprandial glucose spikes, and it reflects glycemic control over 1 to 2 weeks. Okay, so the normal range is of course less than 10 microgram per milliliter. Okay, and it is a very rare test which is generally not done. Okay, then the next test, my friends, is insulin antibody test. The insulin antibody test, IAAB. Okay, the purpose of it is that it detects autoantibodies against insulin in the patients receiving exogenous insulin, may develop allergic reactions, insulin resistance, or erratic glucose control. Also positive in newly diagnosed type 1 diabetic mellitus. Then the sixth rare test, my friends, is the leptin and adiponectin levels. Right? What are these? What is leptin? Leptin is the satiety hormone, often high in obese in type 2 diabetes, but shows leptin resistance. So the type 2 diabetes mellitus patients show high leptin resistance. What is adiponectin? It improves insulin sensitivity, and paradoxically it's low in obese type 2 diabetic mellitic patients. And it is generally a research tool and not generally used in standard diagnostic tests, but it's helpful in understanding the metabolic syndrome profiling and understanding the individual So these two tests can be advised to your high profile clients who are affording or who could afford to better understand the human body physiology and the metabolism. The seventh test, my friends, is the test of glycated albumin. Glycated glycated albumin. Okay, my friends. So a newer alternative to HbA1c, it reflects short-term 2 to 4 week glycemic control, which is again useful in particularly cases of gestational diabetes, hemodialysis patient, and rapid treatment response monitoring. The normal range here for glycated albumin is from 11 to 16%. Right? It should not be more than that. Then we have the next rare test, diagnostic genetic test for genetic testing for MODY. Now, what is MODY? Maturity onset diabetes of the young, right? So, when do you suspect MODY? Diabetes onset in less than 25 years, strong family history, and non obese, insulin dependent for years. Insulin independent for years, I beg your pardon. So, common MODY genes are HNF1A, okay, HNF4A, and GCK, right? These genetic testing confirms diagnosis and prevents misdiagnosis as type 1 or type 2 and modifies treatment. So, if you can get these tests done and if you have these tests, then you are somewhat be inclined to, develop diabetes mellitus. The ninth one, my friends, is continuous glucose monitoring, which is like very trendy in these days, wherein athletes and high performing athletes put a patch of wearable sensors based test on their arms, and it measures interstitial glucose every 5 minutes and gives insight into glycemic variability, time in range, and hyperglycemia trends, right? It is very useful in type 1 diabetics. So whenever a person is having type 1 diabetes, this type of technology is generally used to keep their monitoring in high accuracy to avoid any high risk complication. The 10th test, my friends, is the 10th one, which is advanced lipid particle testing, which is, for example, ApoB LDLP. Okay, so in diabetics have small dense LDL, not always detected on routine lipid profiles. Advanced lipid testing helps identify cardiovascular risk better. So the 11th test, my friends, is the HOMA IR, which is homeostatic model assessment insulin resistance. It is calculated from fasting insulin plus fasting glucose, and it gives insight into insulin resistance severity. The HOMA IR reference range is fasting insulin into blood fasting glucose upon 405. Okay, the 12th test, my friends, is urinary microalbuminuria ACR test. It is an early indicator of diabetic nephropathy. It detects albumin leakage before full-blown proteinuria. So ACR, the albumin creatine ratio, normal generally is less than 30 milligram per gram, the full gram. Microalbuminuria starts when the range is from 30 to 300, and full-blown macro is above 300 milligram per grams. The 13th test, my rare test, my friends, is of beta hydroxybutyrate levels, BHB. It is used in suspected DKA, diabetic ketoacidosis patients. BHB, which is beta hydroxybutyrate levels, is predominant ketone body in DKA, more accurate than urine ketone stripes. So this is BHB is highly indicated in patients of diabetic ketoacidosis. And lastly, my friends, we have plasma glucagon and incretin hormones test studied. So GLP-1 and GIP, which we have studied in the video 1, are altered in diabetes, and it affects insulin secretion. And glucagon often is paradoxically elevated in type 2 diabetes mellitus. Okay, friends. So to summarize, my friends, we study the C peptide levels to study the endogenous insulin productions. The GAD65 and IA2 autoimmune type studies are done for type 1 diabetes. The fructosamine test and glycated albumin are short-term glycemic control tests. The 1,5 Ag, which is post-meal glucose spike test, which is done, which we have covered above. And yeah, with that, I guess we have covered all the advanced tests, the rare tests. We have just covered for our learning purpose and for our understanding purpose, but in general the basic test will be the gold standard test, right? So yeah, that is that for right now. And now we move on to the most important and the most challenging part, the clinical scenarios. Okay, now let us go into that part. So now, my friends, we move into cases wherein we'll try to see cases and clinical scenarios and how do we interpret with respect to our diabetes testing, right? So first case number one, a 34-year-old male patient with newly diagnosed diabetes. His BMI is 21. He has no family history of diabetes. He reports weight loss and fatigue. Fasting glucose is 180. HbA1c is 8.4. C-peptide is low and anti-GAD antibodies are positive. What is the most likely diagnosis? So you take a minute, pause the video and analyze, right? And you write down your understanding in this side column of your notebook, okay? And then you confirm with my diagnosis and what I want to portray, and then you see that where did you miss, what did you miss, okay? So the first case, the information I've given you in crisp, in short. So what is the most likely diagnosis? Okay, so the diagnosis for first case, my friends, is LADA, latent autoimmune diabetes in adults. Okay, so LADA presents in adults like type 2 diabetes mellitus, but has autoimmune markers anti-GAD often high. So anti-GAD directly corresponds to LADA. You know, it's often misdiagnosed as type 2 but requires insulin earlier. Okay, so this was the case. So this is very important. You again rewind back, understand the case, and then write in your diagnosis book LADA as the most important, often missed diabetes mellitus type. So now we move into the case 2, my friends. A 50-year-old woman with iron deficiency anemia and fatigue has an HbA1c of 7.5%, but her fasting and postprandial glucose levels are consistently normal. So what is going on in the patient? Okay, so you need to tell me now what is wrong with the patient now. You pause the video, write your interpretations, and then we again come back. Okay, so I hope you have written your interpretations. Now let us move on to the answer. So it is a case of falsely elevated HbA1c due to iron deficiency anemia. Why? Because iron deficiency anemia increases the lifespan of RBCs, falsely raising HbA1c. Always correlate with fasting, PPBS, and consider anemia before labeling a person diabetic. Okay, so this is a clinical tip from my side. The third case we move on to, friends. A 60-year-old diabetic patient has a serum creatinine level of 1 mg per dl. Urine analysis is normal. You order a urine microalbumin test which shows 110 mg per gram. Microalbumin is 110 mg per gram. Creatine. Okay, so what is the diagnosis, my friends? You take a moment, do your test, apply your knowledge, open your textbooks, medicine, or whatever you want, but tell me, what is the most probable diagnosis? Okay, so here we can think of as the answer as early diabetic nephropathy. So why? So creatine and routine urine analysis may still be normal, but microalbuminuria is the earliest sign of nephropathy, and it must be routinely screened. Okay, so now we move on to case 4, my friends. A 42-year-old man develops polyuria and polydipsia 2 weeks after recovering from COVID-19. Random blood sugar is 110 mg per dl. Okay, I'll not use the units now. I'll just directly say the number. The random blood sugar is 310. Okay, 310, not 110. Sorry, 310 is the random blood sugar, and C-peptide is suppressed. C-peptide is low and suppressed. So what is the diagnosis, my friends? Take your time. The answer here probably is new onset diabetes likely triggered by viral islet damage. Islet cells damaged by viral pathogens. Okay, and why? So COVID-19 can unmask diabetes or cause direct islet cell injuries, especially in those who are predisposed to it. So that's why you must have noticed that post COVID era there are lot of newly rise in the diabetic numbers post COVID. Okay, now we move on to case 5, my friends. A 29-year-old woman has acanthosis nigricans and facial hair. Her BMI is 22. Her fasting sugar is 112 and post meal sugar is 182. So what is the most likely syndrome here? It is of course very easily understandable that this is a case of PCOS, but in lean PCOS with insulin resistance and early onset diabetes. So remember that this is a case of lean PCOS, okay, wherein you don't find obesity that much. And why insulin resistance IR may not always manifest with obesity. PCOS related IR is often underdiagnosed in slim patients. Case 6, my friends. A patient is diagnosed with diabetes today. On routine fundoscopy, he already has background diabetic retinopathy, no previous symptom. What does this imply? Okay, so this is what does this imply, my friends? So the answer is that this is a case of diabetes which existed undiagnosed for years. Okay, because now already the microvascular changes have taken place and the patient has been like literally uh, jacked up. So retinopathy takes 5 to 7 years to develop, hence screen for microvascular complications at diagnosis in type 2 diabetes mellitus. Okay, microvasculature, my friends, let me tell you, is one of the worst outcomes of diabetes, and you must keep monitoring and keep checking. Now we move again to our case number 7. Okay, a 55-year-old diabetic male with controlled sugars suddenly develops chest heaviness and collapses. ECG shows no non-ST cell elevation changes. What is your most likely diagnosis? So, to be very honest, it is a case of silent MI due to diabetic autonomic neuropathy. Okay, silent MI due to diabetic autonomic neuropathy, and painless MIs are common in diabetics, as we all know. Even controlled diabetics needs cardiac risk assessment on regular basis. Case number 8, my friends. A 48-year-old man has 3 episodes of skin boils in 6 months. Fasting blood sugar is 132 and HbA1c is 6.7. Okay, so what is the answer? And in this case, what are the next step that we must advise the patient? Okay, so to be very honest, we must start advising the patient some lifestyle therapy changes and recheck sugars postprandially. And why? Because recurrent infections often suggest high post meal sugars or glucose variability. HbA1c alone can miss this. Okay, and as we all know that boils are and recurrent boils are common indications to diagnose, and I mean not confirm, but to keep your ears alert that the patient could have some diabetic involvement in his body, right? So recurrent boils, regular pus infections, recurrent UTIs, you must rule out diabetes mellitus, my friends. Then we move on to case number 9, my friends. Case number 9. A young diabetic presents with abdominal pain, vomiting, and deep breathing. Urine shows negative ketones. Blood shows high beta hydroxybutyrate. So what's happening here? Like we have covered above, this is an advanced case of diabetic ketoacidosis with predominant beta hydroxybutyrate. Urine strip detects acetoacetate but not beta hydroxybutyrate. In severe acidosis, beta hydroxybutyrate dominates. So this is a very bad case of diabetic ketoacidosis. Now we move on to case number 10, my friends. A long-term diabetic on metformin presents with fatigue, numbness in feet, and memory issues. Blood sugar is well controlled. What are the next investigations that you will order here? Please take a moment, pause the video, and write your answers. So here, my friends, the next investigation which we will tell the patient to do is serum vitamin B12 levels. Okay, because metformin can cause vitamin B12 deficiency, and which generally leads to a neuropathy later on. So important to supplement the patient with vitamin B12 supplements and monitor it in long term. Okay, friends. Now we move on to case number 11, my friends. A 52-year-old type 2 diabetes mellitus patient has mild ALT elevation and increased abdominal girth. The ultrasound shows fatty liver. What is your diagnosis? The diagnosis here, you can again pause and then write your diagnosis. The diagnosis here, my friends, is NAFLD, which is non-alcoholic fatty liver disease. Why? Because it is almost universal in diabetics, even when asymptomatic, often missed and adds to insulin resistance. Case 12, my friends. A young nurse has repeated episodes of unexplained hypoglycemia. C peptide is undetectable during attacks. What is your diagnosis? The diagnosis, the most probable diagnosis here could be exogenous insulin misuse. And why? So low C peptide levels with low sugars indicates that insulin injections has to be given, and always suspect in health professionals with no diabetes history. Okay. Case number 13. A 65-year-old male with COPD develops new onset hyperglycemia after starting prednisone 40 mg. HbA1c is normal. So what is happening here? This is again a very common condition when steroids are advised to patients. So this is definitely a case of steroid induced hyperglycemia. Why? Because HbA1c lags behind. Always monitor post lunch and post dinner sugars when on steroids, because whenever you are on steroid, but natural, the sugar levels are going to be elevated, my friends. We move on to case number 14, my friends. A woman presents with frothy urine and ankle swelling. She is not known diabetic. Her fasting sugar is 130, postprandial is 198. Likely explanation. Again, pause the video and tell me the explanation. Okay, so here this is a case of undiagnosed diabetes with early nephropathy. Proteinuria may be the first clue. Diabetes often found after kidney damage is started. Okay, so you remember these clinical tips. And lastly, the 15th and the last clinical scenario, my friends, for you all would be that a 55-year-old diabetic has normal LDL but continues to have CV events, cardiovascular events. Lipoprotein electrophoresis shows small dense LDL. Explanation. So what is this? This is a case of atherogenic dyslipidemia. What happens and why? In type 2 diabetes cases, the LDL particle sizes are altered, and this again gives rise to small dells LDL, and which again gives rise to higher atherogenic potential despite normal LDL-C. So this is again a case, right, my friends? So this was again, friends, what you can say, some insights into your clinical case scenario. Let us take 2 or 3 more cases just for your bonus rounds. So again, a new scenario comes up is a 52-year-old male, BMI is 31, complains of fatigue, polyuria and blurry vision for the past 6 months. No prior health checkups and acanthosis nigricus is present. The test shows results of 164 fasting blood sugar, postprandial is 223 and HbA1c is 8.2. The most probable diagnosis here, of course, like you all could easily diagnose, is a case of type 2 diabetes mellitus, and the reasoning that we give here is obesity, insulin resistance, features, classical symptoms and elevated sugars confirm the diagnosis. Okay, friends. Another diagnosis to confirm the type 1 diabetes, we can just go through this case. So 16-year-old female, underweight, presents with sudden weight loss, vomiting, excessive thirst, ketonuria is present. Investigation done shows random blood sugar 356, 356 is the random blood sugar. Urine in ketones is present 3 plus, the blood pH is 7.1 and HbA1c is 10. So diagnosis is new onset type 1 diabetes mellitus with diabetes ketoacidosis. Okay, and reasoning is, of course, as we all know, autoimmune destruction of the beta cells, sudden presentation, ketones, acidosis to point type 1. Confirmatory, my friends. Whew. So with this, my friends, we cover, the diabetes mellitus diagnostic protocols in detail in its depth. We saw the basic test, we saw the advanced test, we saw clinical scenarios, and a lot of material I will be sending to you all at the end of this course to, again strengthen your clinical knowledge, and a lot of activities will be done and covered once we complete our full course of diagnostic tests, right? So with that said, friends, I conclude my first video on diabetes mellitus. We have started from the basic scratch, from statistics to we have covered all the possible clinical scenarios which you need to remember. The rest of the clinical scenarios I will be giving you all at the end of this course in my note format. So do not worry with that. But most important is you start understanding reports deeply, you start understanding and learning rare diagnostic tests as well, so that whenever case comes you are not in a state of confusion. And lastly, you must evolve and you must keep evolving yourself regularly. So once now I have taught you this method of diabetes and the study method of diabetes mellitus, you again go back to your books. Okay, you again revise your old what you can say, your old theories, your old pathologies, and your old, the notes which you have made, that will help you enhance your learning capacity. And of course, like I've said, that please use a green pen. It will again increase your learning and observing capacity to the depth. And lastly, my friends, I guess we have nearly taken 1 hour 45 minutes or 2 hours nearly for diabetes mellitus. The rest of the test will be as detailed, so you have to be little patient with me, right? And this is a lifetime access series, so once the videos are out, you can access it lifetime, right? I will highly urge you all to make your own notes like I am making here. Since my handwriting is very bad, I will be, in the end of the lecture, I will be sending you all the typed notes which I have made for you all here, which is here. Okay, so these notes will be given to you at the end of the lecture, friends. And of course, I have not used AI a lot, but I have tried to, gather my data, go through each and every website of America's Societies of Medicine, Diabetes Mellitus, ADA, and of course our Indian Medical Associations Society, IMA. And I've tried to compile good and high quality notes, okay, which you will not find in AI or chat GPT for you all. So yeah, I'm doing a lot of work, and if you have given me 555, I'll make sure that I give you content in return worth of 55,000, okay, 100x. We will not talk below that. So with that said, my friends, I conclude this video, and I really wish you all the very best in your new learning journey, and I hope you all become excellent proficient clinicians, physicians, and lastly great homeopaths. Okay, so maybe interpreting, maybe in the future I can integrate homeopathic aspects as well to this clinical course, so you can buy it up as a top up maybe later on if I get time to understand homeopathic through to understand diabetes through homeopathic point of view and its important therapeutics. So yeah, we can do that in later in life ahead. We have a long way to go. And again, lastly, I apologize if there is little disturbance in my noise in the voice here, because the metro work is constantly going throughout my, I mean, next to my house 24/7, right? That's why I am completely shifting my state and moving on to a new state wherein probably and hopefully I will make my own studio, and for that I will need your help, and yeah, I'll need your support financially as well, because this startup which I'm doing is again bootstrapping, right? I do not have any fundings, and yeah, it's not like I'm begging or something, but yeah, I'm just hoping that you all support me so that I can, deliver you all better results with better and high quality material, right? So with that said, my friends, I end this video here, and thank you very much for patiently listening to me, and I wish you all the very best, and I'll see you all in the next test very soon, okay, in the next week. So goodbye, take care, and please do take good care of your health, and I hope none of us get diabetes mellitus 2 type 2 ever in our lives. Okay, if at all by chance you ever get it, don't worry, I'm always there to help you all out, and I've learned the best of the best therapeutics. I know some different mechanisms, the miasmatic approaches, and I've done a lot of research homeopathically, but I wanted you all to first know the allopathic or the basic investigation part first, then we move on to the homeopathic part in the later series, in a new series probably someday. So goodbye, take care, thank you very much for patiently listening to me, and keep supporting me. Thank you very much.